there's a specific kind of biological misery that comes when you realize your own plumbing it's failed.
Oh, for sure.
We usually try to ignore those first little warning signs until we're, you know, bargaining with the universe in a doctor's waiting room. But today, we're looking at something truly ubiquitous.
It's the single most common bacterial infection that you see in primary care. I mean, if you haven't had one, you definitely know someone who has.
We're talking about urinary tract infections, or UTIs. And before you tune out because you think you know the drill, drink cranberry juice and take a pill, I want to be really clear about our mission today. We're pulling from Chapter 50 on infectious diseases to look at the mechanisms of this invasion. We're not just looking at how to deal with it. We're looking at the biological warfare that's taking place inside the body.
And it really is warfare. That isn't just a metaphor. The urinary tract is designed to be a sterile fortress.
A fortress? I like that.
Biologically, it's hostile territory for bacteria. It has flow, it has acidity, it has immune markers. So when a UTI happens, it actually represents a catastrophic failure of your body's, its territory defense systems.
That's the angle I want to explore. Not just, I got sick, but how did the fortress fall?
Yeah.
And maybe more importantly, once the walls are breached, why is the counterattack, the treatment, so incredibly specific?
Yeah.
Because looking at the data, the whole one-size-fits-all antibiotic approach is, it's actually dangerous.
It is. It really is. We need to decode the strategy behind the treatment.
Yeah.
Why do we treat a young woman differently than an older man?
Right.
Why do we panic about a fever in one context, but then we might strictly ignore bacteria in a catheterized patient in another?
Okay.
It all comes down to the specific biology of the host and, of course, the invader.
So let's map the battlefield. Medical literature draws a really hard line between the lower tract and the upper tract. And I think to the layperson, it all just feels like bathroom trouble, right? But clinically, these are two completely different worlds.
They're different worlds with very different stakes. The lower tract is, it's made up of the bladder, that's cystitis.
Cystitis, okay.
And the urethra, which is urethritis. It can also include prostatitis in men.
And this is the classic presentation we all know.
Yeah.
The common symptoms.
Right. This is where you get dysuria, that burning sensation, the urgency, the frequency, maybe some, suprapubic heaviness.
So the bacteria are kind of banging on the gates.
Exactly. It's uncomfortable. It disrupts your whole life. But the infection is generally contained within the storage vessel, within the bladder.
But the upper tract, that's where we get into pyelonephritis, which we read about.
That is the kidney itself. And that is where the stakes change completely. You have to remember, the kidneys are highly, highly vascular organs.
Meaning lots of blood flow.
Tons of blood flow. They get about 20 to 25% of your total cardiac output. They are constantly filtering your entire blood volume.
So if the bacteria break into the kidney, they're not just in a storage tank anymore. They're standing right next to the highway.
That's the perfect analogy. If bacteria ascend the ureters and they breach the kidney tissue, the parenchyma, they have a VIP pass straight into your bloodstream.
Wow.
That's how a simple UTI becomes urosepsis. And that's why the symptoms shift from just burning to high fevers, nausea, vomiting, and very specifically flank pain, that deep, deep ache in the lower back.
That distinction, contained versus a systemic threat, that seems to drive the urgency of treatment. But the source material also leans really heavily on another classification, complicated versus uncomplicated.
Right.
And I'll be honest, my first thought was that complicated just went, harder to cure. But it seems to be much more about the anatomy of the patient.
It describes the terrain. An uncomplicated UTI is almost exclusively found in premenopausal, non-pregnant women who have totally normal anatomy.
So the pipes are straight, the flow is good, immune system's working as expected.
Exactly. The system is working. In that case, the infection is just a temporary glitch in an otherwise working system. But complicated means the terrain itself is compromised. It implies there's a functional or structural abnormality that is actively helping the bacteria survive.
So if you're male, it's automatically complicated. Is that the rule?
Generally, yes, because male anatomy resists infection so well that if one does occur, we have to assume something is wrong.
I see.
If you're pregnant, it's complicated. If you have a kidney stone, a catheter, diabetes, or immunosuppression, all complicated.
The plumbing analogy from the text really, really clicked for me here. Uncomplicated is like a drain that's just got some gunk in it.
Right.
Complicated is a drain where the pipe is physically bent, or maybe there's a tree root growing through it.
Or the pump isn't working. I mean, think about flow as a primary defense mechanism. We call it the washout effect.
You're just flushing things out.
Every single time you void, you are mechanically flushing invaders out of the system. So if you have an enlarged prostate benign prostatic hypertrophy, or maybe a neurologic deficit, like a spinal cord injury, that stops the bladder from emptying fully, you get stasis.
Stagnant water. It's the perfect incubator.
Exactly. And bacteria love stasis. If a stone blocks the flow, the bacteria can just hide behind the stone. If the bladder doesn't empty, they multiply in that little residual pool of urine.
Oh, okay.
And that's why treating a complicated UTI is so difficult. You're not just fighting the bug, you're fighting the environment that's helping the bug thrive.
Before we get to the bugs themselves, there's one more definition that really caught my eye because I think a lot of people suffer from this loop. Recurrent UTIs.
Oh, absolutely.
The source says this is defined as 2 infections in 6 months, or 3 in a year.
It's a massive source of frustration for patients. They feel like they just can't get clean, you know. But there's a really crucial biological distinction we have to make here. Reinfection versus relapse.
And I think most people would assume it's a relapse. They think, oh, the antibiotic didn't work, the bug is back.
And that happens for sure. We call that relapse when the original organism was never fully killed off. Maybe it was hiding in a little crypt in the bladder wall, or the dose was too low, something like that.
Right.
But the data shows that the vast majority of recurrent UTIs, we are talking 80% or more, are actually reinfections.
So the first bug actually died. This is a totally new invasion.
It is a brand new invasion from the outside, usually coming from the fecal reservoir. It might even be the same species, like E. coli, but it's a new colony, a new event.
Wow. That changes the entire philosophy of treatment. I mean, if it's a relapse, you need a bigger hammer to kill the survivor.
Yeah.
But if it's reinfection,
You need better walls.
you need better walls.
Precisely. If you treat a reinfection like a relapse, just throwing more and more antibiotics at it, you're not solving the core problem, which is susceptibility. You need to look at prophylaxis or behavioral changes to stop the invasion from even starting in the first place.
Okay, let's talk about the invaders. The source calls out one specific public enemy number 1.
Escherichia coli, the heavyweight champion of UTIs.
E. coli accounts for 80 to 90% of community-acquired infections. But here's my question.
Yeah.
E. coli lives in the bowel. It's right next door.
Yeah.
But plenty of bacteria live next door. Why is E. coli so good at breaking in? Is it just about proximity?
Proximity is definitely part of it, especially in women where the urethra is shorter and closer to the anal verge.
Yeah.
But it's really about evolutionary engineering. E. coli has evolved specific virulence factors, and the most important one is called the P. fimbriae.
P. fimbriae. That sounds like some kind of sci-fi gadget.
You can think of them like microscopic grappling hooks or mountain climbing gear. The cells in your bladder, the uroepithelium, they're slippery by design.
Sure.
They're designed to shed and wash things away. But uropathogenic E. coli, the kind that causes UTIs, have these fimbriae that chemically bind to specific receptors on the bladder wall.
So when you urinate, attempting that whole washout defense,
Yeah.
the E. coli is literally strapped in. It's holding on for dear life.
It hangs on against the tidal wave. And not only does it hang on, it's motile. It has flagella. It can actually swim upstream against the flow of urine.
No way.
It is an organism that is perfectly designed to ascend the tract.
That's terrifyingly impressive.
Yeah.
But the source mentions that the villain roster changes, right? It depends on the environment. If I'm in a hospital, E. coli isn't necessarily the main threat anymore.
No, not at all. In a hospital setting, what we call nosocomial infections, or in patients with complicated anatomy, the dominance of E. coli drops to below 50%. This is where you start to see the opportunists.
I know what we're looking at here. What are the names?
The tougher bugs. Pseudomonas aeruginosa, Enterococci, Klebsiella. Proteus is another really interesting one. It produces an enzyme called urease.
Urease, okay.
And that enzyme actually splits urea, makes the urine alkaline, and that change in pH causes kidney stones to form. The bacteria literally builds a stone fortress around itself to hide in.
That is incredible. And Pseudomonas, I feel like that name always comes up when things go really wrong.
Pseudomonas is a nightmare organism. It just is. It thrives in moist environments, hospital sinks, respirators, catheters.
Oh, wow.
And it has high intrinsic resistance to many, many antibiotics. It even has something called an efflux pump that literally pumps antibiotics out of its cell before they can do their job.
So if a patient gets a UTI in the ICU, You absolutely can't just assume it's E. coli and give them a standard pill.
Absolutely not. You have to assume it might be a resistant organism from the get-go. You have to bring out the heavy artillery immediately, because if it is Pseudomonas, the scat community drugs won't even scratch it.
This brings us to the detective work. Diagnosis. I think most people operate on the assumption, it burns when I pee, so I must have a UTI. But the source is really strict about what it calls the numbers game.
Right, because symptoms are subjective, biology is objective. In clinical practice, we rely on quantitative urine cultures. We're looking for what we call significant bacteriuria.
And the magic number mentioned in the text is 100,000.
100,000 colony-forming units, or CFU, per milliliter. That's the traditional cutoff to distinguish between contamination, just some skin bacteria that fell in the cup and true infection.
Because the sample has to pass through the end of the urethra, which isn't sterile, right? So you're always going to get some bacteria in there.
Exactly. We call them urethral contaminants. So we need a threshold that tells us, okay, this is way too many bacteria to be just an accident.
But is that 100,000 number a hard wall? Is it absolute?
It's more of a guideline. There's definitely nuance. If a young woman comes in with classic textbook symptoms, dysuria, urgency, and we only find, say, 1,000 CFUs of E. coli, we still treat it as an infection. The symptoms plus the specific bug equal a diagnosis in that case. But if a patient is asymptomatic or the symptoms are really vague, we stick hard to that 100,000 line to avoid overtreatment.
Now, in the real world, we don't always wait for a culture, which can take a couple of days. We use the dipstick.
The urinalysis, yeah.
I want to drill down on the chemistry here because the source mentions two specific tests, nitrite and leukocyte esterase. How do these actually work?
It's really clever chemistry. Let's look at nitrite first. Your urine naturally contains nitrates with an A from your diet, from vegetables, proteins.
Okay.
The family of bacteria that causes most UTIs, the Enterobacteriaceae, like E. coli and Klebsiella, they produce an enzyme called nitrate reductase.
So they eat the nitrate and then excrete nitrite.
Essentially, yes. They reduce it chemically. So if the dipstick turns pink for nitrate, you have pretty solid proof that those specific bugs are present and they're metabolically active.
But the source noted a trap here. It said nitrite negative doesn't mean no infection.
Sharp catch. This is where the chemistry really matters. Remember I said Enterobacteriaceae?
Yeah.
Well, bugs like Staphylococcus, Saprophyticus, or Enterococcus do not produce that enzyme. They don't convert nitrate.
So you could have a bladder full of staph and the nitrate test will be completely, totally clean.
Correct. That's a classic false negative. And that is why we also have to look at leukocyte esterase.
Which detects the body's reaction, not the bug itself. Is that right?
That's it, exactly. It detects an enzyme produced by leukocytes, your white blood cells, specifically neutrophils. If that part of the stick turns purple, it tells us pyuria. It means the immune system has deployed troops to the bladder.
So nitrite identifies the specific type of intruder, and leukocyte esterase just identifies that there's a war going on.
That is the perfect way to frame it.
I want to pivot now to a section that I found really, really vital, especially for caregivers, the elderly. The source calls this the chameleon effect.
This is such a critical takeaway. As we age, our physiology changes. We experience something called immunosenescence. The immune system just gets a bit slower. But also, the nerve endings in the bladder can become less sensitive.
So they don't feel the burn.
An 80-year-old woman can have a raging high-count UTI and feel absolutely zero burning or urgency.
That's so dangerous. If they don't feel it, how do they even know to seek help?
They don't. The infection just kind of smolders until it causes systemic stress. And in the elderly, that stress manifests neurologically. We see altered mental status.
I mean, like sudden confusion.
Delirium, agitation, lethargy. Sometimes they just stop eating. I've seen families who are convinced their parent has sudden onset dementia or had a small stroke, and it turns out to be a massive E. coli infection.
So the systemic inflammation is crossing the blood-brain barrier before the bladder itself signals pain.
That's a theory, yeah. So the clinical rule, the absolute rule, is if an elderly patient has a sudden, unexplained change in their mental status, you check the urine immediately.
Okay, let's move to the counterattack, the treatment. We've mapped the terrain, we've identified the bug. Now, how do we kill it? The source outlines a strategy shift that I think many listeners might be a little behind on. The era of take these pills for 10 days just to be safe seems to be over for standard cases.
For acute, uncomplicated cystitis, yes, absolutely. We've moved to what we call short-course therapy. We're looking at 3-day regimens, or in some cases, even single doses.
Why shorter? Intuition says more killing power is better.
Well, more isn't better. More is just more toxicity and more side effects. We found that extending treatment for simple cystitis out to 7 or 10 days didn't actually improve the cure rate.
Interesting.
The bacterial load in the bladder is low enough that 3 days is sufficient to wipe it out. But extending the treatment did drastically increase side effects and, crucially, collateral damage to the microbiome.
The good bacteria.
Right, you're carpet bombing the gut and the vagina. And that leads to yeast infections and digestive issues, but it also clears the way for more resistant bugs to move in later on. So shorter is smarter.
What are the weapons of choice here for that short course?
The first-line standard for a long time has been trimethoprim sulfamethoxazole. You probably know it as Bactrim or Septra.
Right.
It's a 3-day course. It works by blocking folate synthesis in the bacteria. It basically starves them.
But the source mentioned that resistance is creeping up.
It is, significantly. The current guideline is, if the resistance rate to that drug in your specific community is over 20%, you have to stop using it as a first-line agent.
20% failure rate is just too high.
It's too high for a standard of care.
So we switch to, what, macrobid?
Nitrofurantoin, yes. And this is a fascinating drug pharmacologically. It has a superpower. It concentrates only in the urine.
How does that even work?
When you swallow it, it gets absorbed into your blood, but it's excreted by the kidneys incredibly fast. It doesn't hang around in the blood or your other tissues. It just rushes straight to the bladder.
So it's like a sniper rifle for the bladder.
Exactly. It achieves these massive concentrations in the urine, enough to kill almost anything, but the systemic levels are negligible.
Which makes it perfect for cystitis.
Perfect for cystitis because it spares the rest of the body, but, and this is a really big but, it makes it completely useless for pyelonephritis.
Because in tylo, the infection is in the kidney tissue itself, not just floating in the urine.
Right. You need a drug that penetrates tissue and blood. Nitrofurantoin can't do that. It just passes right through on its way out.
That brings us to the big guns, the fluoroquinolones. Cipralevaquine. I feel like 10 or 15 years ago, doctors handed these out for everything.
They did. It was the easy button for infections. They kill everything. They penetrate everywhere. But we are really paying the price for that overuse now. The FDA has slapped black box warnings on these drugs.
And black box is the highest level of warning the FDA can issue. What are we risking here?
Tendon rupture. That's the famous one. Your Achilles tendon can literally snap. But also permanent peripheral neuropathy, confusion, aortic aneurysm ruptures. The list is long and serious.
That is absolutely terrifying. So using Cipro for a simple bladder infection is...
It's malpractice, essentially. It's like using a nuclear missile to kill a mosquito. It works, but the collateral damage is completely unacceptable. We reserve these drugs for when we really, really need them.
Which takes us right into Section 4. High stakes. Pyelonephritis. The bacteria have climbed the ureters. The patient has a fever over, 100.9, severe flank pain, maybe they're vomiting.
Now the strategy flips completely. We are no longer worried about sparing the microbiome. We are worried about saving the kidney and preventing sepsis. We need aggressive systemic therapy.
So the bladder sniper, macrobid, is off the table.
Completely out. We need tissue penetration. And this is where the fluoroquinolones like Cipro and Levaquin become the first-line choice for outpatient treatment.
Because they get into the blood and the kidney tissue so effectively.
Exactly. And if the patient is too sick to keep pills down or they look toxic,
then it's hospitalization.
Hospitalization. FAVI antibiotics. We're using broad-spectrum drugs like cephalosporins, aminoglycosides, or even carbapenems. We treat it like the systemic threat that it is.
And the source mentions a follow-up rule here that's different. With simple cystitis, if the burning stops, you assume you're done. But with pylar?
We need proof of cure. You must get a follow-up urine culture about 2 weeks after treatment ends. Why? Because if you leave a little pocket of infection smoldering in the kidney, it can form an abscess or cause permanent scarring and loss of function. You cannot assume it's gone just because the fever broke.
Let's discuss the outliers now. Section 5 covers specific populations where all the standard rules just dissolve. First up, men.
The common myth is men don't get UTIs. The reality is, when they do, we have to assume it's complicated.
And is that just because of the prostate? Is that the main factor?
Anatomy is destiny here. The male urethra is long. It's about 20 centimeters compared to 4 centimeters in women. It's a dry, hostile desert for bacteria to try and climb. So if bacteria do make it all the way to the bladder, it implies something is really wrong with the defenses.
And once they're there, the prostate becomes a kind of bunker for them to hide in.
That's the perfect word for it. The prostate gland communicates directly with the urinary tract. Bacteria can easily colonize the prostate tissue. And here's the problem. The prostate has what we call a blood-prostate barrier. It is very, very difficult for most antibiotics to penetrate into that tissue.
So if you give a man the standard 3-day course of antibiotics that you'd give a woman for cystitis, what happens?
You might clear the bacteria from the urine temporarily, but you won't clear the infection from the prostate. The bacteria just hunker down in the bunker, wait for the drug to clear out, and then they reinfect the bladder a week or two later.
So men are looking at a much, much longer haul for treatment.
6 weeks is often the standard recommendation for prostatitis. You need that prolonged duration to ensure the drug can slowly penetrate the lipid membranes of the prostate cells and eradicate that reservoir.
Wow. That's a massive difference, 3 days versus 6 weeks. Failing to understand that distinction seems like a recipe for creating chronic illness.
It is the #1 cause of recurrent UTIs in men. It's undertreatment.
Okay, next special group, pregnancy. This seems like a biological high-wire act. You have to treat the infection, but you can't hurt the fetus.
The physiology of pregnancy changes absolutely everything. The uterus expands and it can compress the ureters. At the same time, progesterone relaxes all the smooth muscle in the body, so you get this dilation of the entire urinary tract.
Which makes it easier for bacteria to climb up to the kidneys.
Much, much easier. The risk of pyelonephritis is significantly higher in pregnancy. And pyelo in pregnancy is a potential disaster. It can cause premature labor, low birth weight, and even sepsis for the mother.
So the source says we have to screen aggressively. We treat asymptomatic bacteriuria in pregnant women, which is something we don't do for anyone else.
This is the major exception to the don't treat the lab result rule. In a pregnant woman, if we find 100,000 CFUs on a screening culture, we treat it even if she feels perfectly fine. The risk to the pregnancy is just too high to ignore it.
But the drug menu is extremely limited.
Very limited. No tetracyclines. They stain the baby's developing teeth and bones.
Yeah.
No fluoroquinolones. They can damage cartilage development.
And the source specifically warned about sulfonamides like Bactrim in the 3rd trimester.
Right, and this is critical. Sulfa drugs can displace bilirubin from albumin in the baby's blood. The newborn's liver can't handle that huge load of bilirubin, and it crosses the blood-brain barrier. It causes a specific type of brain damage called kernicterus.
So we're really stuck with the old reliables.
Pretty much. Cephalexin, amoxicillin, they're safe, they're effective, they're boring. And boring is good in pregnancy.
The final group I want to touch on is maybe the most counterintuitive and honestly the most philosophical part of this whole deep dive, catheterized patients.
This is, without a doubt, the hardest concept for many clinicians to embrace. It goes against every instinct.
The rule is, if a patient has a long-term catheter and the lab report says there are bacteria in the urine but the patient has 0 symptoms, you do nothing.
You do nothing. You have to understand what a catheter is. It's a plastic tube that's been inserted into a sterile body cavity. It bypasses the sphincters. It is a foreign object that props the door wide open.
So bacteria are inevitably going to find their way in.
Within 30 days, essentially 100% of patients with long-term indwelling catheters will have bacteriuria. The bacteria form a biofilm, a kind of slime layer on the plastic. They live there now.
But they aren't infecting the patient in the traditional sense.
We call it colonization. They are squatters. They're living in the urine, but they aren't invading the bladder tissue. The patient has no fever, no pain, no leukocytosis, which is a high white blood cell count. They feel fine.
But the instinct is to fix the lab result. We see bacteria on a report, we want to kill them.
Why is that the wrong move here?
Because you cannot sterilize the catheter. It's impossible. If you give antibiotics, you'll kill all the sensitive bacteria, the WIMPs, but you leave the resistant ones behind. You have now cleared the playing field for the superbugs to take over, the Pseudomonas, the VRE, the MRSA.
You are actively training the enemy. You're creating a super soldier.
You are. You turn a benign colonization into a future multi-drug resistant infection. And as soon as the drug course is over, the bacteria come right back anyway because the catheter is still there. So the strategy is a kind of masterful inaction.
Exactly. Or the best strategy is to remove the source of the problem. If you can, take the catheter out. If you change the catheter, you physically remove the biofilm. Oftentimes, that alone clears the bacteria without any drugs.
It's a real lesson in restraint. We usually think of medicine as intervention, but in this case, the highest form of medicine is knowing when not to act.
Treat the patient, not the lab result. That is the golden rule of medicine, and this is the perfect example of it.
So let's zoom out. We've gone from just a burning sensation to full-on biological warfare. We've learned that E. coli uses microscopic grappling hooks, that the elderly might just look confused rather than act in pain.
And that men need a marathon of treatment while women might just need a sprint.
Right. And that the big guns, like Cipro, should probably stay in the holster, unless we are dealing with a true tissue invasion, like a kidney infection. I want to leave our listeners with a thought that came from that catheter section. We live in a world where we want to sterilize everything. We want a pill for every number that looks wrong on a chart. But this deep dive really suggests that sometimes the most sophisticated medical decision is to coexist with the biology around us, rather than trying to scorch the earth.
It raises a really profound question, doesn't it? Are we creating our own worst enemies by trying to control every single variable? In the case of UTIs, especially with catheters, the source makes it clear that the best defense is simply not to escalate the war until you absolutely have to.
Something to mull over. Thanks for diving deep with us today. And stay hydrated, everyone.